Good afternoon. So I hear this isn't working, so God help you. I had to start off my normal self. Now I'll get serious at the work we do. I first just want to say that we're very happy at SAMHSA that we're able to come here to this forum and actually talk about what I call the hidden secret of prevention, which is the work that SAMHSA does with prevention of substance abuse and mental health disorders. It's an incredibly humbling experience, and hopefully in a little while you'll understand why, because we sort of feel like we're over here and all the action is over here, and my job, which I've been asked to do, is to try to bring us a little bit together. You'll find out at the end I'm very good at deflecting and giving you back the same problem. So our mostly what I want to share with you today is our approaches to prevention and its evolution. I want you to know how we became who we are. I think that will be very helpful in you to understand our use of evidence-based practices and the workforce that's out there for you to work with, and hopefully we can connect better with health. Our desperate need of integration. We are working very hard together within SAMHSA, between our mental health partners and our substance abuse partners, to bring our worlds together so that under behavioral health we can bring behavioral health prevention closer to primary care. And the opportunities and challenges with all of this conversation will meet. So for our part, prevention is a part of behavioral health. We are truly embracing that, and I thought I'd tell you a little bit about our structure at SAMHSA. It will also help you understand why, when we go through the overlapping problems, learning about the levels of risk, learning about our collaborations and such, that I think it's important for you to know that we are separated in the federal government. We have a long reach, and then at other times it feels pretty crowded. And what I mean by that is SAMHSA has 4 separate appropriations. So even though we have it in us to want to integrate with each other, we have problems, let alone integrating with the outside world. We do all our work in the states and the communities. Separating our appropriations for substance abuse prevention has one appropriation, substance abuse treatment has another, mental health has another, and then everything else left in SAMHSA, including our data and quality, is under the other. We have now an internal mission of sorts that we are fondly calling that SAMHSA is the public health agency that is bringing behavioral health into primary care. So we're very much on the same page. So how did we evolve in the substance abuse world? And I'll show you how mental health then became part of the overall vision or of the prevention, of SAMHSA's prevention field. So in the 80s, and we've heard a lot about this, the world of substance abuse prevention came alive. The reason why it came alive is scientists, prevention scientists, like David Hawkins, who's sitting here in the front, came out and rolled out and taught the prevention field, substance abuse field, around science-based approaches to looking at how we reduce risk factors and increase protective factors or increase strengths. That became pivotal to our success because substance abuse preventionists were feeling in the 80s a little bit unappreciated, and we had a reputation of doing things by what our gut told us to do. We didn't really have a structure, we didn't have a science, we just kind of did things in the community that needed to be done. You had an accident and you lost, or crash rather, and lost 4 kids to a car crash. You did something about it in your community. You weren't quite sure what. My favorite story with that to illustrate, there used to be a program, I won't use the name of it, but it was a very popular program in the 80s, actually very early 80s, that used puppets in the schools. And so once one school said it was a great program, another school decided to use it, and then another and another. Well, there was no evidence behind this program, and more importantly than that, it did not fit everybody's needs. So the program was not a success. And when you try so hard to get programs in the schools, and then you don't have the successful outcomes that you're hoping for, it becomes even harder to knock on the door and go back in. So then we quickly moved to the 90s when we really became known with the science and understood it, because that's when our IOM folks, thank you very much, began to publish documents that describe the prevention science in both, but it was always labeled mental health prevention and behavioral health prevention, both in 1994 and then again in 2009. We lived by these documents. Now remember, in the 90s, SAMHSA still had not connected substance abuse and mental health prevention approaches. Prevention in mental health wasn't even talked about as much. Not that the programming wasn't being done, it was just not a field of study. Substance abuse prevention left off the word mental health, left off even the word interventions in some cases, and looked at universal selected and indicated prevention strategies, forgetting a huge part of what this science brought to us. We currently go to where we are today, and we are now, we feel very much integrated. We're using our data. We have a strategic initiative grants we used to have. Now we have the Partnerships for Success grants. We follow the strategic 5-step logic model process that basically, real quickly, is that we teach communities and schools and states how to assess for their data, their needs assessment, how to go and find the right program using how to learn how to use the data and how to read the data, then selecting the evidence-based program. We're that sophisticated in prevention that we can select an evidence-based practice that can mitigate the work that we do on a community, state, and school level. This has brought both mental health and substance abuse further together as we're moving forward. So in the development of evidence-based practices, what I really want to highlight for you, and it sort of is a reason why I think we're here, is we've been working with many of our scientists all along over the last 3 decades. So we have a huge workforce in prevention, substance abuse prevention, that has been taught directly by some of our friends, Dr. Botvin, Dr. Embry, Dr. Hawkins, Dr. Spoth, just to mention 4 of the ones that came to my head while we were having lunch. But we're also currently involved in a very interesting project, because one of our problems, as has been said today, is both adhering to fidelity and sustainability, and not to mention scaling up. So we have a program called CPIM, which is funded by NIDA and is led by our own Dr. Kellum and Dr. Brown. And we are working, they are doing the majority of the work. We're working with mental health and substance abuse in SAMHSA's office to look at 4 specific programs. One in the community, one that's focusing on underage drinking, one that's focusing on suicide, and the last is focusing on school programming. So where are we going to go now? And here's the hard part for us, and this is where we need the most help. SAMHSA is committed in moving towards healthcare integration. The problem with SAMHSA's programs are that our primary mission in substance abuse prevention is on for programs that are not necessarily intervention. So they're not seeing a light at the end of the tunnel for funding, and they're not seeing their connection to overall health care. What they're seeing is the work that they're doing is going to disappear, which is so not true, but it's very hard to get an entire workforce to gear up to a world that's focusing now on healthcare very quickly, and educate the federal workers in SAMHSA, educate the states, educate the communities, and help them see their role in connecting with primary care. Their goal is not to be funded. Their goal is to bring their expertise, their talents, and their science implementation and connect it with healthcare. SAMHSA is considering funding, well, in the President's budget for 2015, we have a very exciting proposal out there. We're hoping that it goes through, which is taking substance abuse dollars. Remember, for appropriations, taking substance abuse prevention dollar and offering it up in the mental health communities to add a substance abuse component in the science, which has so many shared risk factors. It makes so much sense. The similar families, sometimes the same young people, working in the same schools in the communities, and taking mental health money and offering it up into the substance abuse community world, so that community providers, drug-free communities, as well as our SAMHSA-funded communities, can work together and learn from each other on the ground. And we're hoping that what this small pilot project will do is will help our community programming understand the complexities of both worlds, and will help with our fidelity, our programs, and help to connect better all with overall health. Our goal, following the Secretary's plan, is to focus on health and not sickness. We feel in substance abuse and mental health disorder prevention, we're currently doing that. So our challenges that we have now is that we are working, and I have several of our mental health and substance abuse partners with me today. We are working very closely together, more than we ever have. And more importantly, if not equally importantly, we have our communities and our states also working under the behavioral health rubric. Now what they're asking for us is, how do we now connect with primary care? Some of our programs will fit very nicely into primary care and are already being considered being funded. Some of our programs I don't think will ever fit into primary care if you're looking at the case of funding. However, they could be a huge asset to the overall health of our nation, because if we don't address some of the issues of substance abuse and mental health disorders, we will not have the well society that we currently are enjoying now and are striving for. We know it's 3 to 4 times the cost of treating someone with diabetes if you do not treat the behavioral health condition. It's 3 times the cost to treat someone with coronary disease if you don't address the behavioral health condition, and 2 times the cost for hypertension. So we know our connection. We need your help. So this is one of the areas, I always forget to do this, and my colleague from NIDA asked me to share this with you, that shows that we're not asking our communities and our states anything more than the federal government is doing. Under this administration, we have had a push, a nice directive, but also the luxury of working collaboratively with our federal partners. The HHS Behavioral Health Coordinating Committee is a committee that is co-chaired by Dr. Howard Koh, who's the Assistant Secretary for Health, and Pam Hyde, who is the administrator for SAMHSA, and they coordinate all 11 agencies within HHS, and we focus on early intervention, prescription drug abuse, teen drinking, integrating behavioral health care with primary care, behavioral health communications, and marijuana, which was just our last ad. We come together on a monthly basis. We share with each of the agencies, have representative on each of these subcommittees, and we're working much closer together, and we're getting results in the federal level, which I think is something that our taxpayers deserve. So these are not questions from you, these are questions from me to you, and asking for help in my closing statement, as I alluded to in the beginning. One of the questions I was talking to our colleagues back in the office is, how can the forum help us over the next 4 years to truly help SAMHSA and our federal partners do a better job in bridging the gap between a full continuum of services for prevention? We have been working with the FAN since 1994. At least that was my early introduction to the FAN of levels. But we so often do forget the promotion and the the universal, which in the primary world under public health is primary prevention. We never speak of environmental prevention, which is the cornerstone of this amazing success that our communities for the Drug-Free Communities program is enjoying, which is a funded program of the Office of National Drug Control Policy that SAMHSA manages. So we need your help. And also, how can SAMHSA assist in helping you come up with new solutions and ideas and connecting primary care in different settings. We want to go past with our success. We want to share our success we're having with the schools. I have seen the good behavior game on this screen 3 or 4 times. We want to do better with bringing that to scale. That's part of the program that the CPIM project is doing, is how can we get this to a level that everyone who wants to do these programs, both in the community and in the schools. And last, how can you help us bring the current mental health and substance use prevention workforce together as a full partner, so that we don't lose all the talent over 3 decades of training of individuals from both in schools, in communities, and in state level, who understands the science of prevention, who lives and breathes the ION documents that you have. And when I was in New York State, I required all my staff to read that book, and if I didn't see a risk and protection chart in their office and one of the first ION book in 1994, they had to come to me and explain to me and recite it. So I knew that they obviously, the reason why they didn't have it locally on their desks is because they had memorized it. It is that important. You have a huge workforce of over 1,700 individuals who understand the science. We just now want to bridge the gap between the work that's on the ground. We have an expression in federal government, boots on the ground. These are boots on the ground people being guided by state individuals, being guided by federal government. We want to do a better job. We know you have some of the answers. Thank you.
Oh, sorry. Yep. Thank you, Director Harding. So our final presenter is Dr. Alex Kemper. Dr. Kemper is a professor of pediatrics at Duke University and a health services researcher who focuses on issues related to the delivery of preventive services. I think the hat he's wearing today is he's a member of the U.S. Preventive Services Task Force and serves as a chair of the Evidence Review Work Group of the Department of Health and Human Services Discretionary Advisory Committee on Heritable Disorders in Newborns and Children. Dr. Kemper's presentation will touch on the methods and processes used by the USPSTF to develop the recommendations for clinical preventive services. Thank you. Do you want me to give you a 5-minute warning?